Very honored to be here, very humbled actually for being honored. So thank you very much for giving me the opportunity. Great speakers here. Learned a lot yesterday, and of course, hoping to share some thoughts with you today. When I got the assignment, I thought to myself, what I want to do with this assignment of maxillary canine labial bone loss, because there's a lot of speakers here and a lot of participants that know how to handle this kind of stuff. Yeah. Oh, sorry. Ooh, okay. Thank you. So I thought I'll show you something a little bit different that may be, oh, you need that to hook me up? Okay. Can you hear me okay? Yeah, thank you. Okay, here we go. So this is the case. Okay, this is obviously a canine with a loss of labial plate. Okay, and I'm sure you all have ideas of how to handle the case. Notice the thin tissue between the premolar, which is an implant-supported crown, and the hole. There's no buccal plate there, right? So I think that qualifies for the title. So how would you handle this case? So, you know, this could be different ways to handle it. And I'm just going to show you one way because I don't think that way is very known. So I hope you'll indulge me. But here we go. So I don't know if anybody ever seen this video. Anyone? Anyone seen it? No? So this is a syringe that's pre-filled with biphasic calcium sulfate. About 66% of the syringe is biphasic calcium sulfate. Another third is dense HA in various particle sizes. And what's happening is that it's set within minutes, just like that, and clings to the host site. And then it converts to bone. And then an implant can be placed into that material. Okay, so we're going to cover that real quick. So calcium sulfate has been used for over a century. It just hasn't been used over a century in maxillofacial surgery, but it has been used in orthopedics and that kind of stuff. Okay, it's extremely biocompatible. Okay, it's bioactive. What does that mean, bioactive? Is it osteoinductive? Is it osteoconductive? Is it osteogenic? To me, bioactive means that it goes into the area, creates a certain response, you get a certain result, and then you won't find it. Okay, if you take a biopsy of a graft site with xenograft or allograft, you'll find particles of xenograft and allograft and bone in between. So you find areas of dead graft, inactive graft, okay, and in between you'll have bone. But with calcium sulfate, you won't find it on a biopsy. It's not going to be there. But you're going to have is either nothing or patient's own bone. Okay, because it's a salt, calcium sulfate, it's a salt. It'll disappear. And it's the only thing it can be replaced by is by the patient's own bone. There won't be any fibrous tissue or anything like that because of the graft. Okay, and I was very surprised to find that it's actually an inducer of osteogenesis. I thought there was a remarkable conclusion to this study that was published in 2010. The problem with the material is that you couldn't set it in the presence of blood and saliva. That's the main issue. There were other substitutes years ago that used to mix it with some other stuff, and it's really got a bad rap. It was basically used just as a carrier of other particles, but it was never used on its own to achieve the result that it could, that you could obtain with it. Okay, so the syringe contains biphasic calcium sulfate, which is, two forms of the of calcium sulfate. One is you're familiar with because it's in your labs if you still pour any stone, or if you're in dental school, depends on the school, they definitely have some stone there. So it's got plaster and gypsum, and then you mix them up in a certain formation. Okay, the formula to mix them, to have it set in the presence of blood and saliva, okay, that's proprietary. There's a patent on it. So that's why I'm showing you here. Don't go home and try to mix it. It's not going to work for you. There's got to be a particular ratio. Okay, it's not like you can go to your bin and sterilize it and put it in the patient. That's not the way to go. Okay, so a microscopic picture of the material that was in that syringe basically will show you the calcium sulfate and all these little rocks around. So the rocks, where's my laser pointer? That's why I wanted to use the thing. So there's large rocks and small rocks. And now there's no rocks because something went dead. Oh, here we go. So there's big rocks, small rocks, okay? And it's just like big rocks, small rocks of dense HA. And it's just like when you are building a wall, right? You're putting the bricks between the cement so it gives it structure. The rocks, the HA here, the dense HA, holds the volume as the graft turns to bone. Now, if we go back a few years, dense HA got a bad rap because it just stays around and doesn't do anything for our implants. Okay, and the allograft got a bad rap also because they don't make bone, and there's a combination of that. And this is the calcium sulfate crystal. So that picture is the key to the whole deal. The patient needs, and you need to create it, basically a dense matrix, compact matrix of calcium sulfate. Because in my opinion, it's the calcium that's the magic here. As the salt dissolves, because, it gets blood from inside, from outside, from top to bottom, from the bone, from the periosteum, from the palate, from the buccal flap, the salt dissolves, and you get a high concentration of calcium ions. And as we know, calcium is in the coagulation cascade. You need calcium to degranulate the platelets. So as the calcium ion concentration is high in that area, it induces a biological response that will generate precipitation of calcium phosphate, and that will get the bone. That's basically the concept. So it's very important to get as dense a matrix as possible, because if it's not dense, or if you mix it with some other stuff, you break up the matrix cohesion, you're going to get nothing. You're going to get nothing as a result of the calcium sulfate. You're going to get whatever it is. If you mix it, let's say, with allograft, it's the allograft that's going to do something for you, not the calcium sulfate. But if you have a dense matrix of calcium sulfate, you're going to get bone. So I'm going to show two cases that sort of led me to the logic to treat the first case I showed you in the beginning. They're not ideal cases, but the point is to show you the bone. Okay, so this guy comes in and he's got a flapping front tooth. It's flapping because it's missing the buccal plate and the lingual plate. He's got bone on the mesial and the distal, but the front and back are missing. He's got stuff oozing out. You can only show it to dentists, in breakfast, after breakfast. This is good stuff, right? So he's got all that going on. You can see that, right? So I talked to him about treatment plan and all that, cleaned him up a little bit, antibiotics and that kind of stuff. He came back after 2 weeks. We took some impressions. Basically, I wanted to make the infection chronic as opposed to acute. So to work in a less of an acidic environment, be better for our graft. So he comes back after 2 weeks. I took impressions to make him a temporary, and now I'm going to go in there and take this tooth out. We're going to try to place an implant here, but I don't want to make any incisions. I don't have a lot of bone there. if I make a cut, I'm going to get major shrinkage, vertical shrinkage of tissue, and then I'm going to have a problem. So I thought to myself, I have this material, okay, if I'm able to create some sort of a compact calcium matrix, maybe I'll get some bone. I actually sent this picture of this case to the developer of the material, and he's like, I don't think you're going to get anything here. There's a lot of bone missing. So that's the extraction and implant placement. So I'm going to make him a tooth-borne temp. You can see the blade sliding up there. You can see the tissues moving. Okay, I'm going around and around just to separate the tooth from the tissue. I didn't want to rip the buccal tissue as I'm taking the tooth out because I know it's connected to it. So I'm separating the tooth from the tissue. And I'm going to take the tooth out. Just to minimize the trauma to the gingiva. So the tooth is out. And now I'm going to go and remove the tissue because I want to expose the mesial and distal bone. I want the calcium matrix to be in contact with the bone. If it's in contact with the bone apically, medially, and distally, I'm hoping I'm going to get some sort of bone development, okay? This is how I decided to do this case as opposed to other conventional methods. Okay, so I make sure that the bone on the mesial, distal, and apical is exposed. And now I'm activating the syringe. It's a pre-mixed saline with this calcium matrix. And now you can see my thumb, right? My thumb. So I'm using a power grip. I'm shoving that cement up into that socket. I want to see those granules coming out of his eyeballs. That's how hard I'm pressing. Okay, I want it to come out of the lacrimal ducts. Okay, and I'm now, after I packed it with that, I'm using digital technology to pack it more. My digits, right? My fingers, pressure, diffused, aggressive pressure on the calcium sulfate, and I'm augmenting that pressure with some more pressure with a mirror handle, periosteal handle, whatever you got. Direct pressure, I had some more room, so I added another like half a cc, so it's 1.5 cc's of graft into that socket. I want to overbuild it, and I want a dense calcium sulfate in there. I want it to be surrounded by the bone that I have. This is a collagen plug that I'm suturing on top. Okay, it's inorganic, so I don't care about bacteria. Bacteria's gonna stay away from it because it's actually a basic environment. So I'm not worried about getting infected like with allograft or xenograft granules. Okay, so I'm putting a collagen plug. So 2 syringes, collagen plug, no incisions. That's what I got. Okay, that was nylon sutures, in case you want to know. So that's the day of. All right, so I got a little gap here from the peak, right? A little gap here. But that's the day of. And then that's what it looked like. And then I'm looking at this, right? And if I look at this with the eyes of an allograft or xenograft, that's a failure, right? If you grafted your sites with allograft or xenograft and the patient comes in looking like this, you know this is a huge problem. You have bacterial infiltration, you know, things are not going well, you're losing bone, that's bad. But with the biphasic calcium sulfate, I expect that because I expect the calcium and sulfate to be dissolving. So I'm expecting more gaps now between the molecules over there. And so it's supposed to look radiolucent. And then when it begins to precipitate out as calcium phosphate and reform bone, it's going to get radiopaque. So I'm not worried about that picture because I'm looking at it differently. Okay, next month. Next month. And next month. So it's getting a little bit more radiopaque. So now I'm curious to see what I got because right now it's just this. So I send him for a scan just to see what's going on over there. And I see this is the lateral, okay? So that's a tooth, and that's the pontic, okay? So pontic. So that's what the tooth is missing, okay? And I'm looking at it, and first of all, I see this, I don't know, looks like a buccal plate, but who knows, okay? But it wasn't there before. We know there was nothing here before. And I'm looking at the Huntsville units, and of course at the crest where it's most challenging to generate blood vessels, it's low. That's expected. It's really low here. If you remember previous picture on the mesial, there was a gap. So there's not a lot of density there. But I have some sort of width, okay? I have width. So I figured I have some width and the units are okay. Let me get in there and see what's going on. I was really curious. Sometimes curiosity is not that good, but here I was curious. So I'm putting the blade in and it sinks all the way. I'm not having a good feeling about this, but what's encouraging me is the fact that the tissue looks nice and pink. And it didn't recede too much also. So that's my thoughts as I'm going around. And I really want to see what's going on, so I made a vertical releasing here just to see it, which probably wasn't the best idea, but I wanted to see it. This was like one of my first cases that I've done such an extensive graft. Okay, so I'm working it, and we're gonna flap in a minute and see what we got. I didn't activate a timer, so I hope I'm not gonna go too short or too long. But anyway, we're flapping it, okay? And I'm beginning to see these particles, so I'm not feeling so great about it. But then I remember that there's big and small particles. So most likely the small particles have dissolved already from the bioactivity. The large particles, okay, are still there because it's only been 5 months, 4 months, okay? And I have some sort of a mass there, okay? There's a mass there that wasn't there before, okay? There's a mass there that wasn't there before, and it's sort of bleeding, okay? Now, I'm afraid how it's gonna be reacting, so I decided to use the osteodensification instead of cutting it, okay? I'm not gonna do less aggressive surgery. You see this bouncing piece of thing there, right there? So in the beginning, I thought maybe I should cut it away. Maybe it's some tissue. But then I remembered the low Huntsville units, and I'm thinking this is bone, so I'm not touching it. This is just brand new bone, very poorly vascularized bone. It's attached to the rest of the mass. So I'm not cutting, I'm osteodensifying. If you read the Versa protocols regarding osteodensifying in graft material, they do not encourage that because that's bad, okay? Because you're going to be, because the bone that you usually use is dead bone. So you're going to osteodensify into necrotic bone, so to speak, or sequestered bone. The implant's going to fail. But here, I don't have any dead bone. I have something, and I have HA particles. So I don't care about osteodensifying it. It's bleeding, and I'm good. So I keep going, and I didn't break through the buccal and went into his nose, so I'm happy. And I keep going with that. Okay, and I feel, if you've used Versa, when you osteodensify, you feel the feedback in your hand, and you're pretty steady. I was pretty steady, so I'm very optimistic. And my next thing was to see if the implant's gonna fall out of the buccal or the lingual, and it didn't. It keeps going. You can see when I detach it, it was holding, it torqued out at about 45 Newton centimeters. Okay, and you can see the mass has expanded because of the drills, okay? And now I'm adding more graft. I always add more graft. I used to use mechanized expanders. So for that, I'm adding graft. Even though I osteodensified here, because I flapped the buccal, I'm adding more graft. There's no, if you'll see, there's no reason for a membrane here because the graft, when it sets, it's self-contained. So I don't need a membrane. I don't need any advancing of flaps. As a matter of fact, I don't want the flap to be closed without tension. I want it with tension. I want it to stay in intimate contact against the graft, okay, holding the graft in place. It's not going to move once it's set, and it's not prone to bacterial assault. So I don't need to waste my time with membranes here. Anyway, I closed it. Okay, you don't need to see me suture. We can just move along. How do we move along? Here. Okay. 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 Closure. And this case does not have a happy ending, so we're going to keep moving. This is the implant. He came in, and that's the implant standing in whatever this thing is, and it wasn't there before. I think it's bone. Okay, and that's the uncovery. I didn't see him for about almost 7 months from the implant placement to the uncovery. And I asked him, where were you? I wanted to move in at 4 months. He went to jail. And then he came back. I did the uncovery, and I didn't see him since. So I don't know what happened to this case. This is called geographic success, right? Patient never came back. This is another case. And the reason I'm showing you the case here is because I did a biopsy here just to show what we got as a result of the graft. So this patient comes in, infected. There's no buccal plate on this molar, okay? In this case, no blades were harmed during the procedure. I extracted the tooth using my friendly cowhorn. It's my second favorite forceps. The ash is my first. Anyway, I cleaned it out, and there's no buccal plate. It's just this tissue here. So I curated it out, and same thing. I just grafted with the biphasic calcium sulfate, and this is what it looks like. It doesn't have to go all the way down to the apex, but some of it went, some of it didn't. It doesn't matter. Here I put a collagen membrane, and it's exposed. So it's going to be digested by bacteria real quick. But the graft is working underneath. It's going to bridge over the gap. So patient comes back in 2 weeks. It's not a great photo, but you can see that it's exposed. So if you had allograft here, there would be a failure. If you had xenograft here, it would be a failure because bacteria would digest your collagen membrane and will start digesting and infecting your graft. It will be a failure. But if you look at this, all the periphery here is pink. There's no inflammation. Nothing's going on. It's irrelevant. Okay, the membrane is relevant. The membrane is there just to allow the graft to stay in place so it won't wash out when the patient's functioning. Okay, I don't care about bacteria. Bacteria doesn't touch this. Okay, and so you can see that it healed. Okay, later, a 2-month follow-up, it healed. This is at 2 weeks. Okay, it's open. Okay, and this is at 2 months. We keep going. Okay, this is at 4 months, but I'm opening it up for the implant placement. And the reason for the big flap is to show that there's a buccal plate there. You can see the particles. There's some particles that are still embedded, okay, because they have not been metabolized. So the big particles are still there, but the little particles supposedly gone because there's bone there or something that looks like bone. So I drilled the osteotomy at 50 RPMs, no irrigation, just to get some specimens out and do a biopsy. Okay, it's the implant standing in the distal socket, and then and there's a biopsy. Okay, and what's in the biopsy? Fragments of viable lamellar bone and foreign material. You look at the pathologist, she's a friend of mine. I'm faculty at NYU. And so she's like, what's that blue stuff? Because she writes right here, it says it's blue particles. I said, that's the HA. So following biopsies, she would write that it was graft material, but she didn't know what the foreign material was. But what's missing from the biopsy report? I'm almost done? I'm done? Oh. Okay, let me rush. Can I rush to the last case? No? Okay. Sorry. Okay, I'm done. I'm gonna slowly move away.